Thank you, and thank you, Derek, for the first NAM moderated session you just accomplished. So congratulations. So we're almost back on track. This makes me very happy. Slight neuroticism. I have to say thank you, Hortensia, for stepping in for Stuart Butler. Unfortunately, Stuart had a death in the family, and at the very last minute, and Hortensia agreed to step in for this very interesting and complex panel that we're about to hear from the community level to the state level to the national level about activities that are taking place, particularly around policy and systems reform to drive health equity. I almost don't want to say health equity now, so whatever we're calling it. I'll call it HE, how's that for the moment? So anyway, I'm going to introduce Hortensia, who is one of our advisors as well for our Culture of Health program. She's the Dean and Professor of Social Work. She's a Professor of Preventive Medicine and past Associate Vice Provost for Community Research Initiatives and at the University of Southern California. And we'll have join her up here on the panel, Marissa. So I had the pleasure of meeting Marissa over the summer in Durham. She is the Partnership for a Healthy Durham Coordinator with the Durham County Department of Health. She has a master's in public health from the University of Tennessee, Knoxville. We will also ask Kristen Dillon to also join the panel. She's a family physician and serves as a director of the Pacific Source Columbia Gorge Coordinated Care Organization, a Medicaid accountable care organization. Prior to that, she was in independent primary care practice where she was a family physician for 15 years. Hemi Tewarson, also, if Hemi can, hi, great, welcome. She serves as a director for the National Governors Association Center for Best Practices Health Division. And prior to joining the NGA, she served as a senior attorney for the Office of the General Counsel of the U.S. Government Accountability Office and was in private practice as a health policy attorney. So we have another lawyer in the room. Yay. That's always good. We also want to invite Sue Polis up as well. And Sue is responsible for directing the health and wellness portfolio for the National League of Cities. And prior to the National League of Cities, Ms. Polis led the development and management of the Trust for America's Health. And finally, Alex. Great. So Alex is back. Alex spoke at our January meeting, and we're going to get an update on his work and what his team is doing at CMMI. So he's the director of the Division of Population Health Incentives and Infrastructure in the Preventive and Population Health Group at the Center for Medicare and Medicaid Innovation. His team designs and implements innovative care delivery models focused on improving population health by connecting health systems and communities in order to address multiple determinants of health and achieve better care, better health, and lower costs. So Hortensia, take it away. Thank you again.
Thank you. Well, I want to say, first of all, that I really enjoyed hearing all of the experiences that we just heard about from the community in our table report out. And I think, I don't know if other academics will agree with me, but I feel that communities are way ahead of academic medical centers and universities in general in really understanding from what we've heard today in discussing issues of health equity and really on the ground and engaging in discussions about that. So it was wonderful to hear it. I also thought that was a very powerful video we saw, wasn't that? Right before? Just congratulations, Indy Can, because quite an example of a community organizing to affect policy, which is actually the topic of this panel, policy and systems reform to drive health equity in states and communities. So many times during the day today, we've heard about how a lot of these opportunities or lack of opportunities are structured. And that, so what does that mean? It really means that they have to be addressed at the level of structure, and that usually means policy and systems reform. And so we're here to learn a lot more about how our colleagues are doing that in their communities and in their states. So we actually have two groupings. We have first community individuals from reform, this kind of catalyzing innovative reform in communities, and then two people who are going to talk about catalyzing innovative reform at the state level. So we're going to organize our discussion that way. And I first wanted to just give a little bit of comment to introduce the panel, and then I will ask the first grouping to first give, 3 to so minutes description of the work you do, and then we'll engage in a discussion. I'll ask some questions. So I'll just make a few introductory comments. I noticed today that one of the common threads really across a lot of the morning and afternoon discussion was the need to come together in partnerships across sectors, right, and across communities to achieve policy and systems change. So I'm really excited to get to this point, because in the end, that's something quite essential in this work. I also heard a common thread was the importance of the recognizing of being interconnected and understanding the interconnectedness of the issues that we've discussed during the day, the importance of uplifting each other and rendering each other's history visible, because many people talked about their history being invisible, being rendered invisible. And so making sure we don't do that with each other, right? Instead, we learn about each other's history and uplift it and help each other be visible. So we're going to hear hopefully about some of these, how different communities are doing that. And I want to start with Marissa, and wondered if you would just take a few minutes to introduce yourself, and then we'll go on. Yes.
Okay, I'll go ahead and get started. Everyone can hear me? All right, good afternoon, and thank you for having me here and giving me the opportunity to speak to the group. And I'm having a great time and learning a lot from everyone here. And so the Partnership for a Healthy Durham is a community-wide coalition in multiple health sectors. So we have representatives from nonprofit, community organizations, healthcare, education, transportation, and many other sectors. And so we work collaboratively to impact the mental, physical, social health and well-being of Durham County residents. And so we've been in the current format, housed at the Durham County Department of Public Health with a paid staff person, which is me. And so I provide the support for the coalition. And we have 5 committees. 4 are based on our community health assessment priorities, which we do every 3 years. As we talk to the community, we go door to door and do surveys to find out what are the needs of the community and how they want us to address those issues. So like many of you, our top priorities are access to care, HIV, STIs, obesity and chronic illness, and substance use and mental health. And we have a 5th committee, which is communications, because that was identified as a need in the partnership to improve our internal communications, because we say we have over 500 members. Not everyone comes to the meetings. People can choose how they want to participate, whether it's being on the listserv to get information and share it in the community, whether it's coming to our monthly meetings, whether it's volunteering for activities that don't happen during our meeting times, because we usually meet during the day. And so each of our committees has 2 co-chairs, and then we have 2 overall co-chairs. And Kimberly Monroe in the back, who I'm sitting next to, is one of our former overall partnership co-chairs. And so she's really involved in the community and has been a big help to the partnership. And so So those are priorities, and we also have poverty and education we identify as priorities. We don't have committees around those because there's so much work going on in the community, so we join our partners at their tables. But racial equity is a thread that's going throughout all of our work as well. So we've been really addressing this in the last couple of years, so we're just going to touch on some things that we're doing around racial equity. So I don't need to go into racial equity or health equity, the definitions are for this group. I think we've been talking about it enough today. And so Durham County and the health department actually sponsor racial equity workshops and groundwater presentations. So groundwater presentation is a half-day workshop and to give data around racism and how it looks in systems. And then there's a 2-day workshop which goes into historical racism, and it gives everyone who attends the opportunity to learn about why our systems look the way they do, why certain populations don't fare as well as others, and then what steps that we could take to address these. And so we want to speak the same language because you could talk about achievement gaps, you could talk about disproportionality, you could talk about disparities, but when you look across systems, they all mean the same thing. And so this racial equity training gives us to use the same language. And so we encourage our partnership members and our leadership, our co-chairs of the partnership, to take this training. So as we move forward and continue the work that we're doing, we're all speaking the same language, we all have the same analysis, and so we know what steps we need to take to move forward. And we also have an intern who's working with us, so as we operationalize racial equity, so our intern is working on 3 things. One is looking at what recommendations, we know where we need to move towards, but what does it actually look like on the ground level, working with the community coalition? So she's developing recommendations for that. And she's also looking at inclusiveness or leadership. We tend to have a lot of agency people, a lot of professionals, and we meet during daytime. So, how can we make sure that we're inclusive, hearing from our community and not just having people feel like they can't participate? And she's also looking at, I forget the third one. But she's working around racial equity, how we could incorporate that even more. And so I think I'm out of time. Yes. Okay, I have some things about data, but maybe we'll get to that in the questions that we're doing in the community.
Great, thank you. Yeah, I'm sure you can fit it in later when we get into the discussion. So Kristen, your chance, 3 minutes or so, letting us know what you do.
Sure. Thanks. It's a great opportunity to get to be here today and to learn and be inspired by what everyone in the room is doing. So I'm here representing my home, which is the Columbia River Gorge region in Oregon and Washington. There was some talk about what's going on in rural and frontier, and we're at least another example of a community like that. Our region has about 80,000 people in it. It spans 2 states and 8 counties. It's about 100 miles to drive from one side to the other in any particular direction. So it's about the size of the state of Connecticut. Our populations predominantly are Latinx and Anglo. We do also have significant Native American and Japanese American populations, both of whom have been severely impacted by government-sponsored dislocation and also by land theft. 10% of the people in the county where I live, Hood River County, are undocumented. Many of them living in families that are having mixed status. We're seeing significant health impacts from the stress that's inflicting on them. In rural America, we're seeing the aging of our populations. And poverty is also an issue. 55% of the children in our schools receive free or reduced price school lunch. So I'm here in the spirit of humility to talk about success. That's a little contradictory, but building community health is a team sport. There would be dozens of people up here if you really wanted to see who was doing the work, and it's work that's been going on for decades. So one of my roles is as a bridge between healthcare and health. I was really surprised when we first went to the prize-winning community event. One of the things I heard a bunch of times was, wow, it's so unusual to see someone from healthcare leading health in a community. So there's some sins I feel like me and my people need to atone for. One is certainly the bias and prejudice in the systems we've built. Honestly, the one that worries me more is healthcare is in the process of eating the budgets for everything else. It's getting in the way of building health in our communities because For every dollar we spend on social services, education, welfare, we're putting $2 into healthcare. In any other rich country, that ratio's flipped. And so I think a lot of the job of healthcare is honestly to do better at what we do, get out of the way, and leave some money for the other stuff. A number of the works that we've done in our community have been really connecting and bringing together the existing resources we have. So one is a regional community health assessment and improvement plan with a strong consumer voice, oversampling of poor or immigrant or non-white communities. Another piece of work is a home visiting connection hub. This is a really actually pretty low resource, low cost intervention that for us is helping us to achieve 100% screening of pregnant families and 100% availability of a home visit for every family experiencing a first birth, and bringing together this chaotic patchwork of family serving agencies into not a single agency, but just a cooperating group, so that those of us in healthcare can do single source referrals, single process, and know our patients are getting what they need. We've stood up health IT across our region, both for social service and healthcare, fully funded with the savings from our Medicaid program that we've been able to generate through Better Care. And the final thing is a Bridges to Health hub, which is a pathways coordination hub for community health workers. We have about 100 trained, certified community health workers in our region right now. And their work is now being funded and coordinated, again, through a single center. So they're doing it sort of the way they have, but with better funding and more integrated resources, courtesy of a central agency that's bringing them together.
Thank you. I think it's interesting, some interesting ideas there for rural community-based organizations. So then Sue, would you go next and
Sure,
tell us just 2 or 3 minutes about your work?
Yes, absolutely. Can folks hear me? I think this is working. Well, it's a pleasure to be here on behalf of the National League of Cities. We've had the great fortune of working with the Robert Wood Johnson Foundation over the past year, implementing this Culture of Health grant, the first year of our implementation. So I'm going to share some of the way we're operationalizing that work, some of our key findings, and then some of what the road ahead looks like. So. But I'm lucky in the sense that at the National League of Cities, we have a very long history of working with mayors and city leaders from around the country. So, and they address social determinants every day. So the health piece is really, when you think about social determinants of health, we're spending a lot of time on health, both creating more awareness of the landscape and connecting folks to health stakeholders. So I'm going to talk through a little bit about that today. When we started this work, we wanted to be relevant to mayors and city leaders, so we started with a series of key informant interviews. And mayors are quite frank about what they need to do this work. So the call to action, what's the call to action for mayors and city leaders in addressing social determinants of health? It's the maps, right, that show the great disparities in their cities. That's the call to action. When they look at those disparities in zip codes in the cities that they serve, that they need to do something about that. And then how do we give them a broader frame for what we mean by health? We saw a slide earlier today from the county health rankings and roadmaps. That's been core to our work, giving folks a much bigger set of what really makes up health. And then finally, financing. How do we put all this together in a way that makes sense when most of the city budgets aren't growing, right? They're stagnant or perhaps even declining. So we took all that feedback to heart, and we've operationalized this work through core foundational capacities. And those capacities are a lot of the things we talked about today: data, equity, financing, civic engagement. The work of Indy Kin is so motivational to see that role of the resident voice in this work. And then certainly sustainability. How do we keep building and not shrink what good work is happening, rooted in partnerships? Mayors can't do this work alone. So I don't have a lot of time. I just want to briefly say the real hallmark of this work, we're leading a series of mayors institutes. We're convening mayors on upstream social determinants. They comply competitively to be part of these peer-to-peer dialogues with mayors. We've done them on education and health and housing and health. And really what we're learning is that every city is in a slightly different state of play, But there's a lot we can do to build on their success through better use of data. We have a really exciting partnership with the NYU School of Medicine as they build out their City Health Dashboard that we think will continue to guide and inform our work. We start those Mayor's Institutes with data walks. And then on financing strategies, we're just trying to help coach them when they take a step to really start integrating this work. What are those health system levers that they can be thinking about? Reimbursement for Medicaid, right? If they're doing healthy housing, how do they get that reimbursement for remediation of asthma triggers, as an example? So I'm going to stop there and thank everybody and hope to get to talk more.
Great. So I'm going to ask the three of you some questions, and then later we'll go on to the rest of our panelists. So I wanted to ask you a couple of questions actually about bringing different sectors together on the ground. So, what does it take, based on your experience, to bring different sectors together? And I'm going to add another sort of dimension to that, which is what have been your observations at who has been at your table and who hasn't been at your table?
To start. For the Mayor's Institute dialogue, mayors invite city teams to accompany them to those dialogues. So sometimes that's a community-based organization, sometimes it's a community foundation, sometimes it's whoever's leading a particular area work, policy work for the mayor and city leader. So we try to set the tone in that Mayor's Institute table that you've got to build, right, a broad collection of voices to really make this work. A lot of times mayors and city leaders will know their hospital CEO, but maybe there's an opportunity to have a more strategic partnership and engagement around a particular issue, right? The community health needs assessment, community benefit dollars. Those are the types of things that we're trying to put on the radar and evolve a conversation around anchor institutions, the role of hospitals and universities in these initiatives. Mayors have a big bully pulpit. They can convene, they're natural conveners. So how do we help them think about who needs to be around that table to strengthen those work and efforts?
I'll go ahead and jump in. So I think three things come to my mind that you need to get multiple sectors to the table. And one reason I think the partnership has been so successful is because we are a backbone organization at the health department, and they're somewhat dedicated to this. And so you could pull people together, have people volunteer, but there's not someone to hold people accountable and really fill in those gaps where things may fall through. So I think that really helps in communicating and also building relationships. I think it tends to get underestimated. It's labor intensive. It can be really hard. But I think building relationships, as we've seen from the videos and the examples of work that we've talked about today, is establishing those relationships and having them in place and being able to have people to turn to get things done. And also trust. I know in the work in Durham County, that's one thing that's come up over and over again. And so it's trust related to are your partners going to do what they say they're going to? And not only that, but are they willing to share resources? Because we talk about we're most successful when no one wants to take the credit and it gets done. But sometimes there's turf issues, and sometimes people want to apply for grants, but then they don't want to maybe share the resources or the funding. And so, but work gets done best when we work collaboratively. So looking at sharing resources and also following up on what you're going to do too. So trust and relationship building and having that backbone to make sure things get done.
Yeah, I'll agree with that, especially that idea about backbone organizations, or for us having the right conveners, the right organizations, not too many, but enough to do what needs to be done. I think it's important to have enough anxiety in the system to motivate people to be willing to change, as well as some opportunity at the other side. And our most recent transition happened when Oregon significantly redid the design of its Medicaid program by creating these community-governed regional organizations to administer all of the Medicaid benefits. So physical health, mental health, oral health, transportation, all run through single organizations. And as opposed to many states where an entity maybe could bid for the whole state, the bids are regional. So with the ACA and the expansion of Medicaid, all of a sudden we had the health insurance for 1 in 4 residents of this large chunk of our region. And that gave us a lot of money, a lot of responsibility, and as well as some obligatory requirements about who we needed to have at the table. So we kind of got thrown together, and in a panic because we didn't want to get lumped in with Metro Portland or have something else happen. The community health assessment, the CHA and the community health improvement plan, for us was sort of like the equivalent of the low ropes course for those of you who've been in outdoor education. It was hard enough that it challenged people to work together and do new things. They needed to trust each other, but it wasn't so difficult that some organization was going to go bankrupt or really end up in difficulty over the whole thing. And so for us, it's been a matter of gradually increasing levels of challenge and difficulty in our work together. I think one of the other important pieces coming out of that regional community health assessment, it covers, 4 hospitals in our region, 3 public health agencies, community mental health, public health, United Way. They all did one evaluation together. And then out of that, we were able to have one of the hospitals with community benefit dollars actually fund Paul's position, which is as a collective impact health specialist, or as we call it, the community grant writer. So if you're willing to find partners, work on things that align with the CHIP, you get Paul's help in bringing everyone together, writing the grants, and even in some cases administering and making them happen. So again, opportunity, if you work together, has been a big piece of what's helped us.
Thank you. I have one other question for the 3 of you. This is how much time we have left for this question, so whoever finishes speaking will then go on from there. So where does the funding come from at the community level? So we're talking about cross-sector collaboration, is the common thread housing? Is it healthcare? Is it the health department? Where's transportation in here? So what's the common thread, and where does the funding actually come from for implementing these system-level changes and policy changes, across the board?
Well, I could start. So with our racial equity training, our county has committed to it, so they actually sponsor it. So our partners don't have to pay; they could attend for free. And so, so we're lucky, very lucky to have that. And we have received some money from the state, not a whole lot of money for the work that we do, but a lot of it is grant funding. And we're also looking into private-public partnerships too, because we realize county can't do it all, the city can't do it all. And so we're trying to look at other sources of funding as well, in addition to grants, something that's more stable and sustainable. And so we've discussed having partners also contribute to what we want to do as well. So we're not always looking for outside funding.
I think a big piece, honestly, a lot of what we're doing is what we can with the things we had lying around the house. So using the funding streams that we do have, but trying to use them more smartly, by not duplicating effort unnecessarily, by coordinating well with each other. We've been very fortunate to have Medicaid shared savings from our work, some state level money, a variety of grants, and we've in most cases been able to use that for startup, for programs that then in many cases would be sustainable off funding that we had. And I think the main thing we've done in that to try to ensure that the same old money really drives equity is to bias everything that we do towards the people who we think most would need the benefit from that. And so with the community health assessment, we oversample low income, non-English speaking populations. With our community health worker hub, we specifically seek out, train, and cite the community health workers and the communities that we think can most benefit from them. Because when you're sort of building on the as-is, I think it's easy to lift the boats that were already floating higher in the water and leave some of the others behind.
And from broadly looking at cities, it's a little bit different for each city depending on the issue. Certainly there's, city, state level, federal funds, like in housing. We saw a lot of cities using HUD-related grants and investments. We see braiding and blending of funds at the city level, but we're really trying to figure out, it's never a one-size-fits-all approach. So we've been looking at what cities are doing, right? So pay for success. We have several cities. If you had asked me 2 months ago, are cities using pay for success? I would have said, yeah, but cities are using pay for success. Boise, Idaho, Salt Lake City, Philadelphia, New York, Boston. We're seeing a lot of early work in pay for success, and sometimes those efforts don't work out. Sometimes the learning is this isn't a good tool for us, but maybe they'll then adopt pay for performance. But the nice thing about that is you get all the stakeholders around the table and think about what can be done. So, in the Boise example, they didn't go with pay for success. They ended up doing a pay for performance contract, but they've built a new homeless shelter that was greatly needed in the city using that work. We're also trying to look at cities using anchor institution approaches. We have a number of cities doing this, from Atlanta to cities out in California, a variety of models and efforts. And so that's helping. Newark, New Jersey is a great example of local hiring, local purchasing, with a big emphasis on minority and women-owned businesses. So our job is really not to pick for the cities, but to give them a broad array of possibilities and help them think about who are the partners that can advance that dialogue and those efforts. So our focus in our Mayor's Institute and other work is really to give them a variety of looks at what different cities are doing and align cities as peers based on, are they urban, are they rural, are they small, are they large, are they Republican, or are they Democrat, right? We're trying to give them like city approaches to continue to augment their work and efforts.
So when I served on the Boston Public Health Commission, which is Board of Health for Boston, for 14 years, appointed by Mayor Menino. And I thought that his initiative, especially at the time, was quite innovative and effective, which was he started to require all the directors of the various departments that reported to him, whether it was transportation or housing or employment, to really take a lens, sort of look at the work they were doing through a health lens, which in a way then made lots of other resources available, not directly going to health, but being used to improve health at the system level. I was wondering if any other cities are using that approach.
Well, that's exactly what we're trying to do, is use those models to inform other city efforts. We've seen cities adopt trauma-informed approaches, health and all policy approaches, but our goal is to make those more comprehensive so they're out of just one issue and looking across all city agencies. So in Birmingham, Alabama, there's a really exciting effort that the planning department is leading, bringing all kinds of sectors together based on some work that was done in a neighboring community, but to really drive improvement in the neighborhoods in Birmingham of the greatest need. So bringing together all the different city agencies. So we're trying to spur more of that.
Thank you. So let's move on to Hemi and Alex. So Hemi, you want to start and tell us a little bit, couple of minutes, the clock is there, okay, about your work. You have a little bit longer, Okay.
Great. Well, first of all, it's my privilege to be here, so thank you for having me. I am at the National Governors Association, and for those of you who are not familiar with it, we represent all the governors, so it's a completely bipartisan organization. There are two parts of NJ. I'm in what's called the NJ Center for Best Practices. So what we do is we're really a think tank consultancy for governors and really help them build their policy platforms. And so one of the things I wanted to talk to you all about is how much we've been focusing on this question of social determinants. Because I think it's important, all that you all do at the community level can rise up and inform what's happening at the state level. And our job is to figure out how to fit it into sort of a broad state policy platform that sometimes has some funding, sometimes really helps with organization across the state and is scalable. And it's not always easy to do. It doesn't work in every state the same way. And so we have spent a lot of time thinking about how to put all those pieces together. And I wanted to give you some examples so you could hear about some of the things we're doing on a concrete level. One of the things I did want to highlight for you is when we think about how to do our work, frankly, this year, healthcare has been a tough issue. There's been a lot of uncertainty. There is, on a political level, there is not a uniform way of thinking about healthcare. And so it has been, I love the comment about this has been going on for a long time, thinking about these issues. I agree. But this year has, I think, been difficult in the sense of what is happening with the Medicaid program, what is happening with the individual market, and how is that going to impact everything else that has already been going in motion. From my perspective, I think it has slowed things down because there's been sort of a step back to say, do we have to really think about how financing is going to change with the Medicaid program, which would be a massive change for states, for communities, and most of all for the people that are served by the program. So in the midst of all that, we decided what are going to be our continued priorities to help governors and their staff move forward on things that they have already been doing. And I wanted to just tell you a little bit about those and then some of the specific projects to highlight. So, we organize the work in 6 areas. One is coverage, which we did a lot of work on this year. One is workforce. A third is health system transformation. A fourth is data and analytics, because of course data drives much of what we do. Public health, which has really been consumed, frankly, by the opioids crisis. That's been a focus. But the last one, and I think probably of interest to this group, is behavioral health and social determinants of health. We've had a whole body of work just focused on that piece. And in that area, one of the projects I wanted to talk to you all about is our complex care project. And so what we did with our complex care project was we work with 10 states and 1 territory, red and blue, across the board, different geographic locations across the country. And we said, what is the 5% of your Medicaid population that's the 50% of your spend? And frankly, for some, it's thinking about how you connect with the audience and what platform is going to resonate for different governors, frankly. And this one was, there is a large spend in the Medicaid population. And we can do better with them. So we can improve their outcomes, but we can also reduce costs by, keeping them out of the emergency room, by keeping them out of inpatient. And what we did in that work was we highlighted, looking at all the analytics across the populations, to look at and see the 2 biggest needs for those groups: housing, number 1, number 2, behavioral health. So around that platform, we were able to build in each one of those 10 states and territory programs at the state level to address those pieces. So there was a Housing First initiative, for example, in Michigan that was launched. There was a complex care program in Alaska where they figured out targeted case management for their difficult population just because of the geographic location. And they really were able to connect and build on community providers and linking those community providers to the Medicaid program more effectively. In some states, they use their managed care plans to figure out, okay, push managed care plans to link to community providers, building a much bigger platform for those types of services, because when you think about the individual, they need referrals to other types of services. It's not just about going to their physician or their hospital. It's about what else they need from social supports. And so we found some really great returns on that. If you're interested, we actually are publishing a roadmap next month that identifies for all of the states and the territory that participated the different things that they did. The other thing I just wanted to mention was our rural work, and I know I only have a few more seconds, so I'll stop then. One of the big pushes we have this year also is focus on rural populations. That's a big priority of governors. I wanted you all to be aware of that. And we weren't sure how many states would come in. We have 7 states that came in, a very diverse group of states. And a lot of it is about how do you build behavioral health services for those populations. You're not always going to get, the psychiatrist out there. There isn't that type of workforce. And so how do you build on what's already in the communities and effectively support them? So I feel like that's a really good example of like a statewide lever that's being pulled to really try to link more effectively to communities. And I'll stop there because I know I'm at time and I want to let Alex have a chance to speak. So thank you.
Ditto at this point, because I think I just agree with so much of what I've heard. So I won't do that, though. I will give you my long-winded sort of background. So I'm at the Center for Medicare and Medicaid Services. Maybe just turn it. I will hold it closer. So I'm at the Center for Medicare and Medicaid Services, and specifically at the Center for Medicare and Medicaid Innovation, which is the part of CMS that focuses on the designing and testing of new models of care delivery and ways to pay for those models of care delivery. So we have accountable care organizations that you may be familiar with. We also pay for bundled care and advanced primary care. And the majority of what we do is very much focused on what we can do within the healthcare system to realign incentives to really drive 2 main things. 1, reducing the cost of care, really bending that cost curve down, trying to take us away from the unsustainable growth that we have in the healthcare system. And 2, most importantly, as a physician, certainly for me, is improving the quality of care for our beneficiaries and really sort of moving the needle on health. The majority of the way that we do that is focused on the healthcare system, but I'm in the group in our center that's focused on the opportunity to really leverage prevention and population health to essentially improve health more than you can by just making a more efficient healthcare system, adding a patient navigator to somebody's roster. Those are important things. We definitely need to do them. But if we go back to the diagrams that you were showing earlier, we know that really if we're looking at preventable hospitalizations, preventable care, only 20% of that's going to be impacted by what we do directly with improvements to the healthcare system. There's this big bucket, 40 to 60%, depending on the way you cut up the pie. That's social, that's behavioral, that's where you live, that's environmental determinants of health that we can move some of our programs in to start improving health and through our alternative payment models, really have a situation in which our healthcare systems actually are winning and looking to thrive in that environment. So earlier you heard this concern about healthcare enveloping this space, and I think that the opportunity that we have with alternative payment models is to make sure that if there is a value proposition for healthcare to come into this space, they're doing it in a way that actually is aligned with what you want healthcare to do, and that's certainly the focus of our group. Within my division, I lead a model called the Accountable Health Communities model, which is in 32 communities across the country. There's a lot of similar models with similar names, but ours is squarely focused on upstream determinants of health, and really 5 core areas: housing instability, food insecurity, transportation and utilities assistance needs, and interpersonal violence. These are all areas that drive a lot of excess healthcare utilization that are not generally addressed in a clinical context. And that, quite frankly, a lot of communities have resources to different extents that can address some of these drivers. And so the model is really focused on identifying that need in community members. So we screen universally across our clinical delivery sites for these health-related social needs. And then we have funded a bridge organization or a backbone organization or an integrator, depending on which of the many terms you want to give it, that's really focused on making a strong bridge between that clinical environment where we've now identified need and those community service providers and community organizations that can help meet that need. So it's a really, I think, interesting model that also gives you a sense of, I think, the way that we think about our role in this space. And that's really trying to identify innovation, convene and bring people to the table. And we can do that by funding a community organization. They hear that CMS is backing them. Suddenly other people are coming to the table to talk to them. We can catalyze sort of this kind of community level work by, again, convening that group and adding some cash into there. That never hurts. So that people have a reason to come to the table and to maybe rethink the way that they're working. And then most importantly for us is scaling. So if we're successful in decreasing the cost of care, improving the quality of care, we have a really quick mechanism through the secretary to, it's not as quick as I'm making it out, to actually now expand that to the healthcare system. In comparison to what the old method was, which was essentially having Congress act after a demonstration was completed, we are extremely lithe with the 2 years it takes us to get a program out there. But so I'm happy to sort of take more questions around that.
Yeah, thank you. So let's just stick with that for a minute. So within, this work that you're doing, but also the broader bucket of population health and social determinants of health, what, from your perspective, would it be helpful or for county administrators to do to facilitate either this work or the uptake of the work of your learnings?
So I think about it almost in the opposite way. Again, so I'm sort of, I think of myself as a federal localist. So what we try to do with our programs is kind of set a table and have people come to that table. And then we can, through our position, work certainly at the state level with our state Medicaid agencies, and then again at the federal level to try to harmonize or align what we're doing so that we actually make it so that when people come to that table, they're supported and they know what they can do. So it's more so, what could we do to make sense of all the structure that we've built so that local communities can actually take advantage of it?
I just wondered, I ask that because, yeah, I understand, but whether there was anything that sort of got in their way that would be helpful for your perspective for them to uptake the learning. So, but okay.
Yeah,
so
I think
we'll
there's a
Yeah,
fair bit that gets in their way. I
Yes.
think there's a lot of structure
So it's the
that's
other
hard
way
to interpret.
around. Okay.
Yeah.
So Hemi.
And I just wanted to comment, there are some states where, like Washington State, outside of your program, really took the initiative, frankly, coming from the governor's office and his state leaders, to say, we want to create accountable communities of health in our state. They divided up their 9 regions and they figured out, we want to figure out the health priorities. We want to link the community providers and all the different types of services at that county level, a regional level, and figure out how does that make that work. Now, we worked with them for 2 years to get that done, and I will tell you the challenges was, number one, you had to have the leadership, frankly, both at the community level and the state level. And I feel like that is always key, right, to all these projects. You all in the room are these leaders that are, have all these wonderful projects going on, but you need that leadership. You need funding and need organization. So the funding that they availed themselves of was through Medicaid. So they created a huge Medicaid LM15 waiver. They got upfront investment that allowed them to build infrastructure to help the structure of these regional organizations all the way down from the community level. So I think those are key pieces for success.
We heard a lot today about the need for data, the need for sharing data, collecting data that's not available now. So could you talk to us about the challenges that you see from your 2 different levels about collection of data, sharing data? Thoughts?
I'm glad to start. So from our perspective, data is is a critical issue, obviously, for all of these different things that we've been talking about. From a state perspective, one of the biggest challenges is the sharing across agencies. So figuring out how to bring together corrections, transportation, housing, Medicaid, if you really want to understand what's happening with, the whole person and really figuring out a program that's going to go across all of these agencies, you need the data sharing. And that requires, data sharing agreements, figuring out governance issues, giving up turf, frankly, from the different state agencies. So there's that piece. I'll say the second piece that we've worked a lot about is interoperability at the community level. So figuring out how to make sure that, for example, providers at the community level, not just, physicians, but other types of social service providers can link into these types of systems is, I think, it's a challenge. And I think, we are needing to probably do a lot more investment in that to make sure that there are going to be systems that they can access. And we've heard different challenges on that front. The behavioral health community in particular has been challenged. They don't necessarily want all EHRs in their organizations. It's expensive. It takes time. So, how do we address that if we really want to move to this, everything is interoperable and connecting with one another? So I'm curious if Alex has thoughts on that.
Completely agree with that. I think I'll think about it in 2 different spheres. So within the healthcare system, I think one of the challenges that we're trying to address is that when we talk about these health-related social needs or social determinants or whatever term you want to use, that knowledge or those data points exist in electronic health records, but they're in this sort of narrative under social history. And it's not the same thing where I can really quickly pull out your trend in BMIs. It can't pull out your trend in food insecurity over the last 12 months. And so I think one of the challenges that we have just within the healthcare system is the way that we talk about this, the way that we measure this, the way that we actually can then use that data to leverage both within a healthcare system and across a community, understanding what are those hot spots, where do I need to focus my resources. I think the other point, just to double down on, is that cross-sector piece that's really, really challenging, because I think the healthcare system often groans about the work that we've done in really moving people to electronic health records and whether, there's lots of different opinions on that. But I think when we look across the table then to our social service sectors and where they are with their record systems and when we try to actually, join with them, I think there's just a giant chasm there as well. And so I think if we're really going to be talking about coordinating around the populations that are most vulnerable, we have to be able to share data in a way that also doesn't create more burden for everybody there. The last point I'll make is across sectors, there are lots of laws at the federal level, the state level, and sometimes even the local level that can sometimes make that very challenging. As an example, Head Start, the federal program can't actually know who's in the Head Start program down to a beneficiary level. So it makes it hard for us sometimes to try to do things that we may want to do, and that's in the law. We can't actually change that. So just these examples of ways that we can try to harmonize and work around things, but we also have to sort of be aware of the structure we're working in.
We're going to take questions from the audience in just a minute, but I'm going to come back to my question that I think maybe didn't quite get answered at the beginning, and I'll just ask you to consider if, of course, under ideal conditions and we had a lot more time, say for this panel, who is not at the table here? Yeah, quick.
All right, business community.
Clients.
Employers.
City council members?
Yeah, I think you meant this by clients as well, but like the community members, at least at this immediate panel, but they're in the room.
Every time there's a meeting, it's worth asking that question back home when you're working or whatever your setting is, because we tend to get used to who is on the table and think we got everybody, but that's not always the case. All right, so we have time now for questions from the audience. So we're open. We'll get a microphone.
Okay. I'm just reflecting on sort of a difference in this panel, a number of you, and the things that you talked about when you looked at social conditions and the way that we might have talked about that earlier today. We talked about policy change and system change, and I feel like most of the comments from this panel were about access to services to help people navigate maybe a dysfunctional system where there ought to be some policy change. And so the question is it possible, or how can the healthcare system get engaged beyond connecting to another service delivery to help people with social conditions? So think about advocacy and system change.
So before the panelists respond to that, Hortensia, you can see some questions from our online group as well, so feel free to take questions from the room, take questions online. But Hortensia, when you're speaking, hold the mic really, really close. It's hard to hear you over here in this corner. Thanks.
Hortensia, I'll help you read it off the screen if that helps.
Thank you. That's so small.
No problem.
Okay. So we'll take one response. Yep. Who would like to respond on?
I was going to say, for me, it's an iterative process. Someone else talked about Plan, Do, Study, Act, and actually policy, in my experience, comes that way too. A lot of what we've done recently comes out of significant policy change at the state level for Oregon's Medicaid system. Healthcare and healthcare providers were very much at the table for that. And now we've sort of taken the policy away for 5 years. We've worked with it, figured out what's working, what's not working. We're getting ready for another recontracting cycle in CCO 2.0. And so then it's sort of feeding back. And so I actually, I do feel like healthcare's been quite involved in the healthcare policy and is becoming, I think we're learning to be better advocates for our partners in housing or food, economic development, realizing that we are going to continue to be the health system that gets the worst outcomes of any rich country in the world unless we can support and help change policies for all those other things that really impact people's health.
Did you have something you wanted to add?
Just really add briefly, since there was a question about advocacy, I think, at least from our frame, return on investment, which can sometimes feel like a dirty phrase, I think depends on how you define return, depends on how you define investment. But if you're trying to speak to a policymaker, I think if you can really make a salient argument about how that policy change is going to impact the community, leveraging the examples that you have already up here on the stage or in the room, I think that's an extremely powerful tool because that's sort of the language that they speak.
We'll take one question from, if you'll read one of them.
Okay, so this question is from Poll Everywhere, and it is directed towards Alex. Could Medicaid pay providers to document SDOH using the Z codes that are contained in ICD-10? A little bit of a technical question for the audience.
The short answer is yes, but it's complicated. But certainly yes. With the new ICD-10, there are these Z codes that actually do capture some social situations for patients, and I think coding those is a first step. I think what happens then from a payment standpoint, especially in Medicaid, is very dependent on the state context.
Thank you. And we have a question right here. Go ahead.
Hello? Okay. So this might be a basic question, but for me, you know, filling out these social services forms, and when you go to get food stamps and everything, they want right down to your grandmother's parakeet's doctor's name. And I don't understand how, like, you get a form that says if you want to apply for medical, childcare, and food stamps, and it's one form, and they go back 10 years where you lived, where you went to school, and the whole nine. I'm wondering how. It just seems like it just seems intriguing to me that this data that's collected in counties, that's collected in cities, is not able to be used or put together in a way that makes sense. Like, is it a legal thing? I just don't understand, because it is crossing sectors, it's crossing areas, and you want, without that information, to be completely honest, people do not even apply for services they need because they may not have access to their own, you know, birth certificate, or don't know how to navigate the system. And if, like, this data could be useful for people to actually use the services that are there for them, I just
great
feel like,
question.
I feel like it's just a catch-22, like, what's going on?
Yeah. No, that's a great question. And at least my understanding of some of the challenges is sometimes that information then gets routed to the responsible agency for determining eligibility. So, and when they're determining eligibility, that agency is allowed to use that for determining eligibility. But then if you wanted to share it with another agency, you know, sometimes that agency is not even the Medicaid agency, right? It's the Department of Human Services. When they want to share it with another agency, then that's the barrier, because it's for a different purpose. Like if the Medicaid agency wants to look at, hey, let's put all this together in a database and figure out what are the different needs of the populations, it can be done. But I think it takes careful navigation of both understanding HIPAA, for example, state laws that may have protections. In some states, there's very stringent behavioral health protections for that type of information. So you have to navigate those and sort of understand. And I think, frankly, agencies have been doing business in a certain way for a long time, both at the state level and the federal level, right? It's very siloed based on the way Congress set up the funding in the first place. So that's kind of trickled down at the state level, county level, city level, and that's, you know, it's kind of trying to work within that system and be more flexible is, I think, where states want to go, but that's where some of the challenges is from my perspective.
And that's something we certainly heard we really try to do user-centered design as much as we can, and having to continually prove your poverty again and again and again is an affront to human dignity and is actually a detriment to someone's health and well-being. And so before the information gets to the agency, our community governance entity, the Columbia Gorge Health Council, has actually set up a place where that information can be submitted and stored and saved, and then it can be sort of printed and downloaded and sent to where it needs to go. It's totally voluntary. If someone wants to do independent applications, have their stuff, you know, that's fine. But what we heard from folks is, oh my gosh, if you could store a scan of my pay stub, my birth certificate, my whatever, and then the agency can dispatch it to the people who need it. We're actually pushing the envelope on that a little bit more now to see if the Regional Housing Authority can get funding to actually be the repository for rental history and background checks. Because every time someone applies for housing, it costs them at least $35 to get a background check. That's going to say just the same thing as the one that they just did. So again, trying to build stuff at the community level that can be a voluntary interface and sort of trusted intermediary so that people aren't having to go through those processes again and again.
Thank you. We'll take a question from our viewers online.
Hi. My organization has been part of a citywide coalition around DSRIP in New York City. It's a coalition of CBOs. And my particular organization is advocating around how community needs assessments are carried out and how hospital centers invest in community benefits. And we're trying to change that mix. And so I'm wondering, just from a legal standpoint, since you're with Medicaid, how how community needs assessments are carried out, because I believe that we could create a culture of health there if they looked at different indices.
So I'm not sure that I have a lot of a legal opinion on community health needs assessments, but I do think it really is an interesting tool that we're looking at the way different health systems are using it. I think, you know, a point that you may be making is that still a significant portion of community benefit dollars are going to paying for uncompensated care. But I think if you look at that portion that's not going to that, I think we're starting to see health systems move further away from what would have been maybe comfort zone initiatives, you know, taking care of smoking within their own employees, to moving a little bit more into their community opportunities. I think part of that is the increase in alternative payment models and these sort of other circumstances where they get returns on those investments that they could be making in their communities in response to those community health needs assessments.
So we are done with our time. I wanted to thank our panel members for coming to join us and for sharing your experiences and thoughts. And I wanted to say, you know, just an observation is that although we focused today and in the discussion just because of where, you know, who's here and who's represented, we focus, you'll notice, primarily on the healthcare system, right? On questions rather than on broader issues of policy and systems more broadly. So I just want us to notice that, because these, and we already know this is a full bucket of very complex issues, as we just touched the surface here, but there are also other systems and policies pertaining to non kind of medical care that really are within the social determinants of health framework that we want to consider. So when you go home, just remember to engage in that conversation if you're not doing so already. So thank you very much.